I'd like to share with you two interesting cases of canaloplasty and double hydrus implantation. The first case is of a 63-year-old Caucasian female with primary open-angle glaucoma who suffered a devastating suprachoroidal hemorrhage after a trabeculectomy in her left eye, which is now 2400. We are now operating on her better seeing right eye, which is still correctable to 20/20, but has minus 15 decibels of mean deviation visual field loss and has demonstrated slow progression over the years. Her prior surgical history includes multiple trabeculectomies and bleb needlings, phaco eye stent, and micropulse laser. We are starting with the explantation of her existing eye stent, utilizing a hands-free single-use gonioprism with a piece of the stabilizing skirt cut off on the left side. This is followed by ab interno canaloplasty, performed with an Omni System. We are electing to go left-handed to dilate the nasal and inferior half of Schlemm's canal, assuming that most of the collector channels and aqueous veins are infranasal. Because of the choroidal hemorrhage in her left eye, this patient has been understandably reluctant to have any further incisional surgery on her right eye. But with an IOP of 26, despite 5 topical drug classes, with slow progression on fields, she understood the need to try to do something. We are now implanting the first Hydrus left-handed into the nasal canal of Schlemm, pre-dilated by the Omni System. We discussed many surgical options for this patient. One was glaucoma drainage implants, but her left eye now has corneal edema after an OMED glaucoma valve, and we were concerned about this occurring in her right eye. Endoscopic CPC was another option, but she suffered some mild cystoid macular edema after her micropulse treatment, and we were concerned about this occurring again. We also considered the gap procedure or goniotomy, but were concerned about post-op hyphema, limiting the rapidity of her visual recovery in her only seeing eye. So we finally settled on this canaloplasty and hydrus. I've now moved to sit superiorly and am creating a third supranasal paracentesis. I've angled the microscope to about 50 degrees, and I'm asking the patient to tuck her chin and look slightly downward. This will give good visibility to the inferior angle for the implantation of the second hydrus. Flow studies seem to show that access to 4 to 5 clock hours of the canal is probably the point beyond which there will be diminishing returns. I'm hoping here that the canaloplasty will reactivate the distal outflow system, and the two hydrus implants will keep 6 clock hours of Schlemm's canal stented open, giving us the most bang for the buck. For this patient, the result was quite good. From post-op month 1 to post-op year 1, the IOP has been consistently 11 to 13 millimeters of mercury across 6 post-op visits. However, the patient is still on all the topical drops she was on preoperatively. She is anxious to prevent any further vision loss and has elected to continue all of her medications to keep the IOP as low as possible. She could certainly choose to try tapering off some of the medications in the future if she wishes. Indirect gonioscopy showed excellent position of the two hydrus implants, so I will now remove the OVD with bimanual IA. To prevent hypotony and subsequent blood reflux, I will keep the irrigation running while I hydrate the wounds to finish the case. So in summary, a good qualified success in this monocular patient, allowing for rapid visual recovery and achieving IOP consistently in the low teens on multiple post-op visits out to 1 year. The next case is similar, but slightly different circumstances. This is a young, phakic, 37-year-old Asian active duty service member with juvenile open-angle glaucoma. We are starting the case again with ab interno canaloplasty performed with Omni System. This patient also has severe visual field loss with minus 17 decibel deficit on mean deviation. He has also failed 2 prior trabeculectomies, 1 traditional and 1 with an express shunt. The conjunctiva is badly scarred and not amenable to bleb needling. We'll follow up the canaloplasty with the first hydrus implant sliding into the pre-dilated Schlemm's canal nasally. Preoperatively, this patient had an IOP of 31 on preservative-free prostaglandin and preservative-free dorzolamide timolol combination due to sensitivity to topical preservatives. Once again, we'll move to the superior position and implant a second hydrus in the inferior angle. As with the prior patient, we discussed all other available glaucoma surgeries, but we decided on this combination to avoid the long-term complications of glaucoma drainage implants in this young phakic patient and to avoid hyphema from goniotomies and trabeculotomies. His post-op course was complicated by iris obstruction of the inlets of the hydrus implants, which were treated with the AG laser. Our goal was to try to get his IOP consistently in the low teens, and we got close. The IOP settled in the 12 to 16 range on 3 glaucoma drugs with 2 years of follow-up. So far, on 13 patients who've received this combination, IOP was lowered from a pre-op of 27.1 on 4 medications down to 14.5 on 2.9 medications at 1 year. There were 2 failures, both of whom received subsequent Zen 45. So an interesting, effective, safe, tissue-sparing approach to MIGS in uncontrolled glaucoma without concomitant cataract surgery. Hope you enjoyed it. Thank you for watching.